Welcome to the Nurse Shark Academy Show, a Baxter Professional Services production. Welcome to the Nurse Shark Academy Show, where we're experts in nursing and experts in business. I'm Tina Baxter, your host. The Nurse Shark Academy Show highlights nurse business owners and others in the healthcare field who promote entrepreneurship. Today's episode is how one nurse exceeded expectations to become a nurse executive. And today's guest is Dr. Lendra James.
And, I really don't have that, that inner story that says like, oh, this happened and I became a nurse because of this. It was really, I grew up in East Orange, New Jersey. And, can remember there being, I was at that age where I kind of really didn't know what I wanted to do. And in speaking with my guidance counselor in high school, he mentioned that he was like, oh, well, there's a program. So where I grew up, we weren't really expected to go to 4-year colleges, and we weren't really encouraged to or pushed. That's why I bring that up. However, there was a technical program in the area where I lived at the program at the time, and it was a LPN. It was an LPN program. And the counselor said, hey, there's an LPN program. It's a 10-month LPN program. I'm sure you can easily gain entry into this program. So I did, got into the program.
Break free and come feel the sun with the Nurse Shark Academy. Nurses, are you ready to break free from the grind and build something of your own? It's time to take your skills beyond the bedside and step into entrepreneurship. Join our free webinar, Break Free, the Nurse's Path to Entrepreneurship, where you'll learn how to shift your mindset, explore nurse-owned business ideas, and get the exact steps to launch your own business. This is your time to take control of your career and create a future you love. Seats are limited, so grab yours now. Join us at the nursesharkacademy.biz. Break free and come feel the sun with the Nurse Shark Academy. Welcome to the Nurse Shark Academy Show. I'm Tina Baxter, your host. The Nurse Shark Academy Show highlights nurse business owners and others in the healthcare field who promote entrepreneurship. We interview nurse leaders and encourage them to tell their story. My mission is for you to own your seat at the table of nurse entrepreneurship, gaining the confidence, skills, and freedom to live your life on your own terms. You will dream big and expand your consciousness as an entrepreneur. Join us and support these wonderful nurse entrepreneurs and leaders. Today's guest is Dr. Lendra James of Premier Infusions and Wellness. Welcome to the show, Dr. James.
Thank you so much for having me. It's Dr. Lendra, and everyone wants to put an A in there, but it's okay. It's
Lendra. Okay.
Yeah.
You know what? I always do that. So that's why I try to practice Lendra. I had another lady that had a very unusual name, so I had to practice that one a lot. So I was getting that right.
It's fine. My mother, she royally messes up everyone's name, and I'm always like, no, like she can't say a name as simple as Danielle. It's something about the yell. She says Danelle. Mm-hmm. It's Danielle. Just say Danielle. Yeah, she royally messes up everyone's name. I always feel bad. Like I have a friend, his name is Marique, and she calls him Marie. He's not French. His name is not Marie. Like that's it. But anyway, how are you?
I'm great. You know what? My mom does the same thing too. Of course, even her own children, she'll just say, "You know who you are."
I love it. I love it.
Okay, well, let's jump in and ask that first question of what made you become a nurse?
You know what? It's so funny. I was asked this question recently, and I really don't have that that inner story that says like, oh, this happened and I became a nurse because of this. It was really, I grew up in East Orange, New Jersey, and can remember there being, I was at that age where I kind of really didn't know what I wanted to do. And in speaking with my guidance counselor in high school, he mentioned that he was like, oh, well, there's a program. So where I grew up, we weren't really expected to go to 4-year colleges, and we weren't really encouraged to or pushed. That's why I bring that up. However, There was a technical program in the area where I lived at the program at the time, and it was a LPN. It was an LPN program. And the counselor said, hey, there's an LPN program. It's a 10-month LPN program. I'm sure you can easily gain entry into this program. So I did, got into the program. And again, I was like I said, 17, 18 at the time, got into the program. And a month before the program was supposed to start, apparently the program lost its funding. And so everyone that was enrolled and supposed to go into the program at the time automatically gained entry into the county college nursing program. So now at this point, I'm like, okay, from LPN to RN, I guess I'm doing this, right? So
That was awesome.
I ended up going to nursing school, got my, diploma degree in nursing, and the rest is history.
Okay, see there, you never know. One door closes, but another door opens up, and
There you go.
I maybe there's a reason why they lost that funding because you need to be in the RN program. So you said you went to and got your diploma program. What did you do next? What was your first job as a nurse?
So my first job as a nurse, I worked on a neuroscience unit. So, but before it became let me backtrack. Before it became the neuroscience unit, it was like one of those mishmash units. So it was still titled a neuro unit, but we used to get neurology, urology patients, some remote telemetry, and then eventually, what happened within my first year of working there, the hospital had became this neuroscience center of New Jersey, and it had built this whole new floor where it was a neuro ICU, neuro step down, and neuromed surge, and we were trained in all of the areas so that we can float between all three areas. And eventually I became the charge nurse on the intermediate care side. So that's where I kind of really stayed for the duration of the time.
Okay, okay. And then how did you decide to go back to school? Because I know there's probably a story there.
so so at this point, so when I first started ADN, there was nothing wrong, and it's still nothing wrong with ADN.
No.
So let me be very clear when I say that, with associate degree nursing. There was starting to be a push for magnet, right? So a lot of organizations started pushing for magnet, and in doing so, it started encouraging a lot of nurses to go back for their bachelor's, and that's pretty much what I did. I was like, oh, okay, let me go back to my bachelor's. So I went back for my bachelor's. I didn't go back for my bachelor's honestly until probably about, I was a nurse at least maybe 8 or 9 years before I went back for my bachelor's. And then once I got my bachelor's, because I was traveling, I was doing travel nursing, I was doing agency work, I was, just taking care of my, life was lifing, right, as they say.
Mm-hmm.
And so once I did go back for my bachelor's, it was like, okay, like, you know what? Let's go back to my go back to my graduate degree. I had worked across the country, working as a travel nurse, ended up landing a position in California and stayed there for about 3 years. And that's when I went back to school for my graduate degree. And once I finished my graduate degree, I, transitioned back to the East Coast, and, where I started working in leadership. And like I said, the rest is really history from there. From leadership, I worked my way up in nursing leadership and went back to school eventually for my doctorate degree, and transitioned to being a entrepreneur after completing my doctorate degree program.
Okay. So what is your doctorate degree program in?
Doctor of nursing practice. Because I was in leadership, my doctorate degree is in healthcare executive leadership.
Okay. Okay. Because that's kind of important because there's so many different avenues that you can go in even your graduate and your master's and PhD programs or DNP programs. So I want our listeners to hear that. And the fact that you waited 8 years after you got started, you were working to go back and get your BSN. I want our nurses to hear that because you don't have to take the traditional route of going to 4-year college and getting your BSN and going to get your master's you don't have to do it all at once. And I think a lot of people feel like they have to do it all at once. I talk to a lot of new nurses and they either they want to go back to school and do it all at the same time, or they don't want to ever go back to school.
So I think for me initially, if I'm being completely honest, I really didn't have any plans on going back to school when I completed my diploma, my associate degree in nursing, and because when I for me anyway, my siblings and I, we're first generation PhDs and doctorate degree students, so it wasn't really a push for us to go back and do 4 years, and in my mind at the time, I was doing what I needed to do and taking care of my family off of with my associate's degree. And I was happy and fine with my associate's degree. And let's be very clear, after taking that NCLEX exam, I didn't want to take another exam. After finishing nursing school the first time, I was
Mhm.
not interested in going back and being tortured anymore. But when I went back for my bachelor's, it wasn't bad at all, and I was just like, oh, okay, like I could do this. Like this is after going through what I went through, if I can conquer that, I could definitely do a bachelor's. And that's what I kept saying to myself. Oh, I could definitely do a master's. I could definitely do a doctorate degree. So it was just the energy was on after that.
It was interesting because I have a bachelor's in biology and then I got a bachelor's as a nurse. And when I finished nursing school, I was like, yeah, I'm not going back to school. I'm done. And about a year or 2 years after I graduated, I had an opportunity to take a parish nursing class. And I thought, I'm going to take it for graduate credit just to see if I can do this on a graduate level because I was supervisor at the hospital on second shift. It was like there's a lot going on, always on call. And I thought, let me see if I could just pass this one class. And that's how I got into grad school. It was like, okay, I can do this, and ended up being a double major. So there you go.
I can tell. I'm telling you, sometimes you can't imagine sometimes where the encouragement comes from. I'm telling you.
Yes, yes. So where you said you were traveling as a travel nurse, and so I imagine that got you to seeing a lot of change, from hospital to hospital, area to area. Because I tell you, having been in the Midwest for a long time, done some traveling myself on the East Coast, and meeting some nurses on the West Coast, it's different where you are, how things go. So kind of talk about that because I want some of our listeners to understand that nursing is not just this one thing that you're tied into.
And thank you for bringing that up because I think that's so important. We get used to, and I think this is why a lot of people, some people don't travel because they become creatures of habits and they don't like change or they're not interested in changing. However, when you do travel, it really opens your mind up to so many different. And let me give you an example. I remember I traveled to Hawaii. Now I was on the island of Maui, and it was like the only hospital on the island, and there were so many things that you wouldn't even think of. They would probably write an incident report if something like some of the things that, but that's their culture and that's their environment, and that's the thing about going across the country. You see so many different things. I remember they would do EGDs at the bedside there. So you would have like an EGD. Now you go back on the East Coast, and when I would go back and I would share with my colleagues in New Jersey, they didn't believe me, and I was like, no, they do. Like they do the EGDs at the bedside here. You go to some places and that's unheard of.
Yeah.
Or I can remember, like, there's just so many different things that like working in Chicago, you'd be surprised how the nurses are really charged with doing just about everything. You have nurses calling consults, and some things, for me, coming from environments where I came from, I would push back on that. I'm like, why am I calling your consult? Like, this is your patient. The doctors are asking me questions that you need to answer. And then when they're asking me, well, why is this consult? You didn't give any clear clarification why this. Now, don't get me wrong. I know
Hmm.
some, if they have unit secretaries who call consults. So, yes, the nurses can do that. However, at this particular facility, the nurses were the unit secretaries.
Mm.
Right? So you're calling consults, and again, these are just some examples of the different things that you see and the different things that you have to get used to when you travel. And for me, because I've had been doing it, a lot of my career, there were some things that I would push back on, but for the most part, you really have to be adaptable. But you do learn so much, and I do can attribute my expertise and a lot of the skills that I gained through travel nursing, through working at, whether they were large institutions, small institutions. I do attribute a lot of my skills and even my leadership skills. I attribute it to travel nursing and working across the country.
You see so much when you work with nurses from different parts of the country, and I'm going to say different parts of the world. I had
Mhm.
a nurse that was originally from Jamaica and on the show. And the difference between being a nurse in Jamaica and a nurse in the US was vastly different because basically you did it all. So she was a midwife and birthing babies and doing whatever she needed to do because that's again their culture and what they're allowed to do. And then I had a chance to talk to the very first nurse psychotherapist out of Canada, where she has her bachelor's degree in nursing and she can hang out her shingle and be a nurse therapist. And I think that's wonderful. Yeah.
Right, right. Yeah, no, it's amazing how the profession can mean something and be something and interpret it so differently all over. And that's the beauty of what we do. It really is.
What's lovely about nursing is that you don't have to be tied to any specific specialty. Because I can imagine you did other specialties too besides neuro, right? If you're
Oh yeah,
traveling, yeah.
absolutely.
Mhm.
Yeah, I've done cardiac, neurotrauma, ortho, resource nursing to say the few, nursing supervision, leadership. I mean yeah, the only area I can say I haven't worked in is the maternal health pediatric areas. And even with maternal health, I mean, in some travel assignments, depending on where I was working, there were occasions where I worked in the area, but I wasn't nothing L&D, let's say that, no labor and delivery, anything like that. Maternal health is actually not as, when you say, if you've never worked there and they're telling you like, oh, you're going to maternal health, and you're like, what? You know, like, well, but just, you don't have to do, couplet care. They don't make you do any of that. You're really taking care of the mom. And then from my perspective, please, maternal health nurses, please do not kill me when I say this. From my perspective, is a lot of it is like post-surgical care for the mom and really just caring for the mom after she have the baby. So, but that's not my specialty. My specialty areas would really be, like I said, those intermediate care environments, some ICU experience, some ER experience, but more cardiac, neuro trauma, those areas that I named for sure.
Well, I'm going to tell you, L&D is not my specialty either. My specialty is geriatrics and psychiatry.
Oh,
Um,
nice,
I
nice.
did I did a couple weeks in L&D actually with my cousin who's an OBGYN. And I knew right then and there that was not for me. you there's that's again that's the beauty of nursing because you can change specialties and figure out what doesn't work for you.
Yep,
Um,
yep.
I worked alongside midwifery students in my graduate program, and the ones that were going into midwifery, they loved it. That was their whole world. They were all excited, and I'm like, God bless you. Okay. Um, and it's because I find it not exciting for me. Kind of the
Mm-hmm.
same thing over again. Have this baby, and so I had said to them, I said, well, it's just the same thing. Every birth is the same, and they're like, oh no, every birth is different. I said, not really, unless something exciting happens, and then you really don't want something exciting to happen. So I better go into geriatrics where something exciting happens every day.
Every day. Every day. So listen, coming from the neuro, oh my gosh, it's like working in psych. It really, really,
Hmm.
really is. It's especially dealing with those the stroke patients, that stroke environment. But then you get a lot of the dementia, the Alzheimer's, right? So a lot of times in that neuro med surge area, or
Hmm.
even the neuro post-operative patients, a lot of times they wake up very confused and they go through, or the ones that have the ICU delirium, and you're dealing with that. So yeah, it is definitely it's definitely the shifts. You come home and you're like, whoo, like, well, how was it last night? Like, I had two patients, and guess what? And
Yeah,
it only takes like one to keep you on your toes all night. So
you
I
know,
get what you mean.
we would get some of that neuro stuff because we would get detoxing patients
Hmm.
who are on
Hmm.
who knows what, right? Or
Oh,
the the TBI patient. That was always the hardest because you're trying to
Oh, yeah.
treat whatever's going on with their head, the psychoses or whatever, but also realizing that it may not get better with medication because they have a
Yes.
traumatic brain injury. And so we got a lot of those things, a lot of developmental disorders that were thrown in the mix. And, so it could be very interesting. I even had a patient in respiratory failure on the psych unit. So,
Oh, wow.
yeah, he went.
I thought they don't go to the psych unit ill. I
Okay,
thought they had
so
to be.
he had a trach, and he decannulated himself, and that was his suicide attempt. So he ended up on our unit, but he kept decannulating himself and going into respiratory failure. And so I'm like, we can tie him down, but we can't we don't have anything but a one oxygen tank over here. Okay. That's all we have. I
Yeah,
said,
right.
so you better go get him, So we ended up having to send him back to medical because he was just too complex for us because we didn't have the equipment to keep him alive. And we had RT come up. Thankfully, we were in a big teaching hospital. So we were able to get all the people in place. But imagine these ambulatory, standalone psych hospitals. Yeah, they probably wouldn't have taken him.
Right, right,
Yeah.
right. I can remember. So I remember during COVID, it was challenging with having commingling COVID patients that were psych patients, and that's exactly what the psych staff where they would say, "Well, we're not equipped and to take care of them over here." But it was COVID, so we had to do what we had to do, and we
Hmm.
had to equip them. Right, we had to make sure that they had the equipment they needed over there because they weren't necessarily. Yes, they were psych patients. It was just the dynamics of it, right? Like, yeah, they were
Right.
psych patients and they needed COVID care, but they weren't appropriate to be on the units because they needed psych care, right? And
Right.
it was just, yeah. So what I'm trying to get at.
Yes.
It was just like one of those, dynamics that was, pretty challenging. But we got through it. But
Yeah,
it
I
was
had a
definitely.
delirious patient that they sent over from the ER. They come from another ER to our ER, and they sent them to me, and I immediately sent them back to ER because I was very familiar with this patient. And I said, he's not psychotic; he's delirious. Found out he had a raging UTI, was in sepsis, ended up in ICU, almost died up there. And I'm thinking, yeah, can you imagine having him on a psych unit? You
I
can't,
get it, right?
you can't
You guys
die on
are
a psych unit.
right.
We will
Right.
code you till you get over there. You will die over there, but you will not die here. It triggers. It triggers the feds coming in, CMS coming in, the state has to come in. It's an investigation that can last a year, no matter what you died of, natural causes. It don't matter. You died on a psych unit. So yeah, we're like, no, we will code you till you get over
Right.
there.
Like you're getting over there to ICU now.
You are not a
Yeah.
DNR on our unit, so I say we're not having that. And we were across the street from the hospital, so you had to from the main hospital. So
Oh, so your facility is detached from the
right, so
hospital.
we would call the
Oh,
ambulance, come get them now.
they'll be on that gurney doing CPR until we get across the
Yep,
street.
if I have to, I said, load him up, let's go. He came in on a gurney, and I took one look at him, and I'm like, no, send him over there. And he ended up in ICU. And so I said, you really need to talk to that other ER that sent him here, because to me, that was an EMTALA violation. They did not properly triage this patient, sent an unstable patient to our ER. Yeah.
Wow.
So, and the crazy thing is, the doctor and the ER called me over to do a consult. So I walked over there and I said, I sent him here. There's no need for a consult. He's delirious. This is not psychosis. I sent him over here because I picked his arm up off the gurney and it just flopped down. He had no idea where he was. It was like obvious. I was like, this is delirium. He's not psychotic. He's not catatonic. If he was catatonic, if I picked his arm up, it would have stayed up here.
Stay there, right? Yeah. Yeah.
Yeah.
Yeah.
So you have to know your specialty, right?
There you go. There you go.
Give a little pushback. Now, what made you decide to go into entrepreneurship? Because you mentioned that when you got your doctorate degree, you decided to be an entrepreneur. What was that about?
So that was about me dealing with a lot of bias and burnout in the, as a healthcare leader. So my businesses are a direct result of just that. And, during my time in leadership, I experienced like a transformative shift in my purpose, I'll say. And the onset of COVID-19 really highlighted the pressing need for self-care, wellness promotion, and really preventative education within the communities. And just witnessing the strain on, healthcare and hospital, the resources and the lack of attention to staff well-being, I chose to redirect my focus towards a greater mission, right? If you say, and that would be self care advocacy. And I started really advocating for myself for self care and getting through the burnout that I had experienced. And so my vision really became to create a lasting legacy that would ensure widespread access to self care and wellness and preventative education. And, recognizing that I was intrigued with the operational side of healthcare, I embarked on becoming an entrepreneur and I launched my own company. Leveraging my leadership skills, my doctor of nursing practice degree, and I am now empower nurses and healthcare professionals to break through from burnout and build generational wealth. And I do that through courses, mentorship, and events. And I empower them to follow their own entrepreneur aspirations and while prioritizing self care. And my self care, the company that you mentioned, is Premier Infusions and Wellness. And we offer IV hydration vitamin therapy, we offer weight loss services and wellness services. And I actually am the founder and CEO of DL James Consulting, and we consult with organizations to bring wellness into the organizations to prevent burnout and improve retention. And we also provide courses like that courses and mentorship that I was mentioning for coaching other nurses and healthcare professionals. And we host events, like we have an upcoming event called the Health and Wealth Expo. It's a live summit where we're going to be really talking about financial literacy, real estate investments, nurse business startups. We're going to have someone talking about government contracting, and that's going to be on October 24th at the National Harbor in Maryland. So that's pretty much what, why I transitioned and what I do for, with my businesses.
Well, that sounds great. And I was just thinking, so could we have like a big old spa day? We get drink mimosas and get massages all day long.
Yes, 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 you can. So there are possibilities for that, and we do more groups, right? More group and organizations. I mean, we still do single IV hydrations as well, but it's more about really. Like we can come to your retreat. Say if your organization was hosting a retreat, we would come to the retreat and provide either wellness service or IV vitamin therapy services. So yes, and we definitely could plan a spa day and provide, facials, vitamin therapy, and while you have your mimosas, absolutely, absolutely. So I mean, we actually offer a concierge service. So we come to you.
Okay.
However, you know, business owners know other business owners, and I've partnered with other estheticians and who actually have locations, and we go to their locations, once a month, and they will be and that's the partnership and the collaboration. So they will provide the massage therapy services, and we will provide the IV hydration or the wellness services. So we make it happen. We make it happen.
Okay. Okay. And so you're now, just so people will know, you're in Pennsylvania. Is that correct?
So we practice in Pennsylvania and New Jersey
Okay.
with Premier Infusions and Wellness. My consulting services, that is all over the country. That's as a consultant.
Okay. So if you're in that area, Pennsylvania, New Jersey, if you're next to New Jersey or Pennsylvania, you can always drive over, right? But for one of your events, but I wanted people to know where to find you, in the country. Um, and I think that's wonderful that you have that service. I'm envisioning like a large retreat center and people just coming from all over.
Yeah, yeah. So, like, say if you were to put together a retreat and you know you were putting together a retreat and you were going to have, I don't know, maybe 200 people or 100 people, you could let us know where it's going to be and we would come to the retreat maybe one of the days you want to be able to provide, like I said, IV vitamin therapy to, or some type of wellness, right? Wellness aspects, maybe talking about, burnout prevention and what that looks like. So we can do that. We would be able to do that as well.
Well, I think there's so much now awareness around burnout and um, what we need to do to take care of ourselves. And I'm seeing where nurses are now saying, hey, wait a minute, what about me? And recognizing that we have to take care of ourselves. And it's not really a flex that you have gone 12 hours and not gone to the bathroom.
Exactly. Exactly.
And,
And
I,
go
I,
ahead.
I was just going to say, I stopped thinking like that. One of the things that I advocate for is taking that vacation time. Why are you saving up your PTO? You may never get to use it that way.
I mean, think about the people who come to work sick,
Hmm.
right? And they're like, "Oh, I didn't, I came to work because I didn't want you guys to work short. I would have rather you stayed home because now you just expose everyone to whatever it is that you have, and now there's going to be probably more call outs. Or to your point, it's not, how do you say a flex? It's not a flex that you came to work and you came to work sick. Like you don't get a medal for that. And these are the things that lead to burnout. And I don't think nurses or healthcare professionals in general, I don't think we really think about that because I mean, I think we have, most people may have good intentions, right? But you have PTO, use it. But then when you really don't need it, when you just want to, take the day off, you use it, but when you need it, you
Yes.
don't, you don't use it. I have a good friend of mine who, and I'm not, obviously I'm not saying no names, but he uses his time for things that, could couldn't you probably took a half a day, or maybe that could have rescheduled that for another day. But then when he needs his time, like recently he had some medical issues. He had all his sick time was gone, but then his medical time was like real short. The way his his paid time off was, where the way it was listed, he didn't have any sick time, and he had to use like other banks that he had to use. But I
Hmm.
say that to say we don't use our time appropriately, and when we should, and then a lot of times, oh, what do we do when we want to go on vacation, right? Especially us nurses who work 12-hour shifts. What do? We'll work that extra shift, like, oh, I'm going to work this extra shift, that extra shift, and guess what, that leads to burnout.
Yep.
It all leads to burnout. So, oh, guess what, someone called out sick, and guess what, now you have to take on that extra patient workload, and now you're annoyed. It all leads to burnout, right? So we have to know, and we have to, have boundaries, right? We have to really start setting boundaries and knowing when to say no. So, and I was just recently telling a friend of mine, she's an LPN, and she stayed for to do a 16-hour shift. She had to be back the next day, and the next day she's calling me in the morning saying like, oh my god, my eyes are so tired, my eyes are bleeding. I'm sure they are, because you
Hmm.
just worked an extra shift and you knew you had to be back in the morning, and you're tired. So why are you
Hmm.
doing this to yourself? And why do we do this to ourselves? And this is where that that wealth aspect comes into play, because most nurses that I know, they have more than one job.
Yeah.
And and we work that way because no one really teaches us about money, right? No one teaches us about having different streams of income, or no one teaches us how to translate our expertise into a business, or into some type of side business, or that can really translate our skill utilize our skills, that doesn't involve us working in the hospital or the nursing home or long-term care, wherever it is, and causing us to be beat down. And that's important. And that's why I host events like the Health and Wealth Expo, so healthcare professionals can really start to look at, again, having other streams of income, or look at what does an IUL mean, looking at their financial literacy, and really understanding, so that when they retire, they can retire and retire comfortably, and they don't have to work until they're 70 years old because they can't retire,
Right.
right? And that's really and that's concerning to me. I know recently someone said, well, I know nurses who work well into their 60s, and it's because they love it. No, they don't. I, I'm sorry. I'm sorry. They don't. Like, you cannot tell me that. I mean, listen, maybe I don't know. Maybe some may say I sound pessimistic, which I am not by far. But I just can't believe that a nurse is 67 years old and she's still working the floor because she loves it. Absolutely not. My mother is very elderly, and I can't see her, and she's and let's be clear, my mother's 75 years old, and she's a healthy 75. Yes, she does have, she's 75, so she goes to the doctor, she has, doctor visits, she has things going on. But that's my point, right? Even the healthiest 67-year-old who's still working as a nurse and still drives, still have all the faculties, all of these great things, you should be vacationing, right? You should be taking care of your grandkids. And I'm not trying to sound, like someone who, but this is what they should. This is my opinion, right?
Mhm.
Because, and why are you still working? Now, it's one thing if they're working per diem, but with you're still working full time and you're still doing all of this overtime because you have all of these bills and you're helping out your kids, it's because something happened along the way that we didn't plan properly. And that's the reality of it.
Well, and I
And it's
think some of
time.
it, I was going to say some of it probably is because we're saddled with student loans too.
Oh, and let's not talk about the student loans. There you go.
Mhm.
Right. And that's what I mean. And that's why where we place our money is so important. And what we do with our money is so important. It's important. And no one teaches us these things. We don't learn this in nursing school. What we in nursing school, we're taught, I mean, listen, we're taught nursing, right? We're taught,
Mhm.
our clinical expertise, and it makes us who we are. But along the way, I don't know, we have to realize that we're onto something. Like, we really have, there's so many, we can really translate our skills. We can be consultants, we can be legal nurse consultants. That was one of my first jobs, one of my first businesses, I should say. And, I'm still a legal nurse consultant. However, but we can take our consulting services and translate them. It doesn't have to just be legal nurse consulting. We can have,
Exactly.
businesses like IV Hydration. We can have private duty businesses. We can have staffing agencies. And let's be clear, you don't even really have to be a nurse to have a staffing agency. But as a nurse, you know what it should be like, right? So, but
Exactly.
we're not taught budgeting. Listen, I can go on and on and on, and I don't want to ramble, but I say all this to say there's a lot that we can do as nurses, and it's really time to take our power back and start utilizing our expertise to do, things that can involve us, being prepared to leave a legacy for our families.
One of the things that a lot of times keeps nurses from striking out, particularly in areas where they have to possibly bill insurance, are these antiquated regulations by the insurance company that says we need a physician to do anything. And in so many different ways, we do not need a physician to tell us how to be a nurse. And I think we need to have more nurses step into that public policy arena and help change some of that. I would love to see nurses consulting with some of these insurance companies that don't want to panel nurses and credential nurses to provide services that they can independently bill for. Um, and I'm looking forward to the day when we're no longer tied into the room like a maid, right? And that we're no longer seen as the handmaiden of the physician, which we are not. You know, we have our own scope, our own practice, our own skills, and I think that nurses are really beginning to say, "Hey, wait a minute, we want to be into the forefront and be reimbursed for the things that we do, but recognized for the things that we do." And I have to say, if you go back and look at the history of nursing, you will see that nurses used to write prescriptions.
Talk
nurses,
about it.
yeah, nurses would work in the home and they would do the plan of care. The only time you ever saw the doctor was if you had to have a surgery or something. But most of the time it was the nurses doing a lot of that work. And I think we've gotten away from that when we moved nursing care into the hospitals, because the hospitals wanted the nurses to be trained there, because guess what? We were free labor. And so you were tied to that hospital and you had to work there after you got trained, because you were living on campus at the hospital. They'd call you in and somebody need to scrub the floor. So let's get the nurses to do it. So you were doing all the jobs, the orderly, everything as a student nurse. And so we've really built that hierarchical system where it says the doctors is at the top. And I think it really shouldn't be that way, because the doctors have great expertise. Don't get me wrong, I'm not anti-physician, but
Right.
I also see that there's a lot of gaps that happen because we're so focused on what the doctor does and you forget all the day to day. Hey, what's going to happen when they go home and they're going to fall apart? Who's going to help them, change their dressing? It's not going to be the doctor. The doctor's not going to show up to your house to help you change your dressing. Those days are gone. The doctors don't make house visits hardly ever anymore. I mean, some do, don't get me wrong, but they're not going to be there day to day to change your dressing. They're not going to be there to give you that education. That falls to the nurse. And I think that we need to exercise our voices and tell people what we do and what we can do. And then it needs to be reflected in regulations.
Absolutely. I agree with everything you said wholeheartedly, because to your point, the doctors aren't the one at the bedside. And there is this misconception that,
Mm-hmm.
the nurses are at the doctor's beck and call. Now, there times and or are there occasions where doctors are, you're trying to get a hold of a doctor and you're trying to advocate for your patient, and that has been challenging, or the doctor won't give you an order for something. That's a different scenario. However, I'm talking about when the nurses are trying to advocate for you and they're telling you, oh, well, my doctor said I can have this, or my doctor said. It doesn't work like that. Right. And I think there's a
Mm-hmm.
huge misunderstanding of how things work in the hospital, as far as when, as a nurse who's taking care of, I don't know, 3, 4, 5 patients at the time. And, you're trying to care for all of the patients. And then you have, your patients calling you and there's, oh, well, can you get me some water? Because my doctor said, so I'm here. And I think, and I mentioned this because I don't think there's a good understanding that nurses are not just there to give you a bed bath. Nurses are not
Right.
just there to get your water. Nurses are not just there to, warm up your food, right? So
Right.
nurses are not just there to do that. We are trained professionals who are taking care of you from head to toe, and we are with you from 8 to 12 hours a day, right? And we're with you sometimes longer than we're with our families, and we're giving you our all while we're with you. And for to diminish the role to something as if, I'm just here to, put you on a bedpan, it's demeaning, right? But I think that comes from a lot of what you said, right? We call the nurse to scrub the floor. We call the nurse to, all of that history, not understanding that nurses has transformed in such a unique way that we have created our own. We've created our own journey and empowered ourselves to be so much more than just someone who cleans up the floor, right? And I
Right.
can remember when COVID first happened, it was, well, we'll just have one nurse, and the nurse will go into the rooms and the nurse would be everything. So the nurse became the housekeeper, she became dietary, no one was going into these patients' rooms. The nurse became housekeeping. The nurse
Mm-hmm.
had to basically go into the room and do everything once she went in there. So when she went in there to do the medication, she had to bring the meal tray. She had to take out the garbage, and I can even remember one time one of the housekeepers gave one of my nurses, it's not funny, but, hey, do you mind just taking the mop over the floor while you're in there? And like, she came to me and she was just like, Lendra, I've had enough. Like, she said, someone has to come into these rooms aside from the nurses. And
Mm-hmm.
I get that, there was a safety aspect of it, but there was also a fear aspect of it. We were all afraid. We were
Right.
all afraid. So you're just sending these, but the brave ones, right? The nurses were going into these rooms, doing what they had to do, and still being told that you had to reuse masks, reuse gowns, all these
Yes.
things you had to do. But guess what? We still went into the rooms and we did it. So there's a level of respect that really needs to come with the nursing, with being a nurse. And unfortunately, that respect, and again, this is my opinion, and I've talked to plenty of nurses who feel the same way, that respect is lacking. And in order for us to really see a change, something needs to be done at the political level, at the
Yes.
legislative level, so that we can really enforce policies that will really bring respect back to the profession, and that so many people are not leaving and exiting the bedside, because we need our bedside nurses. A lot of them are just not feeling respected, for whether it's from burnout, whether it's from a lack of respect, whether it's from the institution, or whether it's from the people that we're caring for. It's unfortunate. That's what's happening.
When I was rounding in the nursing homes, as a nurse practitioner, I would get complaints from my room's too cold. Um, my food is cold. Why is my food late? I don't know. I came to see you about your medical care. I have no idea. I don't actually work for the nursing home. But I would find myself having to say, okay, Mrs. Smith is complaining because her food is cold. Somebody go warm her food up. It was interesting. Um, the patients, the residents just, they complained to whoever would listen, right? And so I found myself, well, I don't work in maintenance, so I can't fix whatever's broken, fix my TV. I can't fix your TV. They just see you as a warm body in there to do anything for them. And I get that they have needs, they want to get their needs taken care of. But I think there has to be that understanding that the nurse can't be everybody. I can't be housekeeping, dietary, the maintenance person, the nurse, the CNA, and sometimes, doggone it, even the doctor, because they may not show up on time. I had a friend whose daughter was in labor, and the doctor and the midwife were nowhere to be found. And so, guess who was going to have to catch that baby? Thankfully, her mom was a nurse, and they had some nurses there. So, sometimes we do it all.
We do, and that's what leads to our burnout, because we
Hmm.
do it all, right? A lot of times, we like you said, sometimes the TV isn't working, and you're in with another patient, and you could be in with another patient, you could be drawing blood, starting IV, giving, trying
Hmm.
to beat that sepsis protocol, and getting that antibiotic hung, and then someone's calling you, and they want the nurse, right? They don't press the call bell and want say the nursing assistant, or can anyone come, or and everyone's calling the nurse. So now you stop what you're doing to go in there to see what the patient want, and what they want. My remote isn't working.
Hmm.
So, and that's my point. And these are the type of things that so we become everyone, and we do it with a smile, and we do it with grace. But what happens, those are the type of things that lead to our burnout. These are the type of things that lead to us being able to say, like, I can't do this, or feeling like, we have to do everything and we have to be everyone. And it's because and this is how we start neglecting ourselves. And it's because we're used to giving our all to all of our patients, to our units, the organizations where we're used to giving our all. And then when you start feeling like you're not getting anything back, that's where some of that, that maybe it's like resentment starts to set in, or what am I doing, or why am I doing this? And, again, it leads to ultimately you starting to really question the profession. And again, that's not what we want. But we do feel like we are everything to everyone. And when we neglect ourselves, we start neglecting our families, and we don't want that. We want to be able to bring everything that I'm giving to you as a patient. I should be able to give that to my family. And far too often we're not able to do that, because when we get home, we just want to sit down. Sometimes we don't even want to talk. We finally went to the bathroom after 12 hours. We, it's amazing how you can go a 12-hour shift and walk out the door, and finally saying to myself, like, oh my God, I didn't go to the bathroom today. Like,
Or I didn't
oh,
take a sip of
it's
water,
amazing.
or I didn't get
Or I
a,
didn't take a sip of water.
I didn't
Exactly.
eat. Yeah.
Exactly. And these are the things you need nourishment, right? We need hydration. These are the things that we need. And if we don't, we will burn out. We will.
You know, I have to say, some of the regulatory bodies that govern nursing, I think, and I know there's many content creators that have made comedy sketches out of this stuff, but I think they worry about the dumbest stuff and forget about the most important things. Why are you worried about a nurse having a cup of water at the nurse's station? I mean,
No,
seriously,
don't you know? Don't it's infection control.
put a lid on it. Get over it. We have Stanley cups now, okay? It's okay. But yet the residents we want to make, or the patients, we make sure they have their water in their room at all times, and we encourage them to drink. But heaven forbid you take a sip of water in the nurse's station, right? I mean, I think sometimes we just look for ways to bog down nurses. There was a directive that came out about having glass items and metal items in my office, and I'm just like, what? Say what now? Because somebody could hurt themselves with it. Who's going to be playing with my stuff?
Yeah, I can remember when they you couldn't put tape. You can't put tape on like the computers. Like if you tape something so you can't do that. You can't put tape on the wow because it's infection control. The things or everything that you hang up, even in your office, has to be laminated and it has to. And I'm just like, this is in my office. And to your point, who's coming in here with like laboratory specimens? But and I get what you're saying. Rules are rules. If these are your rules, fine. But how about, when it was again, and I'm, bringing up COVID again. How about coming here and tell us how we can better protect ourselves instead of telling the nurses, oh, it's so because we don't have N95s, but telling nurses, well, yeah, just wear a surgical mask and go into the room.
Hmm.
Then you just gave 150 nurses caught COVID and now they're all out of work. How about that?
Yep.
So you see what I mean? So we worry about the things that are like, you're worried about tape and you worry about this piece of paper not being laminated,
Or
but
my
you
fluffy
weren't worried
animals.
about right, but you weren't worried about the nurses who were going into taking care of these patients and catching COVID because you were telling them it's okay to wear a surgical mask and not an N95. I don't get
Mhm.
it. So yeah, there's definitely needs to be a revisit to a lot of these because a lot of these policies have been put in place for how long, right? And
Right.
when they're updated, who's updating them, right? The update is probably an add-on as opposed to let's and again I'm speaking I have never worked in for the Department of Health. Let's be clear. I've never worked for the Joint Commission. Let's be very clear. I'm speaking from a perspective as someone who has written and updated policies and have been on committees for policy and procedure updates. And a lot of times these policies, I can say I remember one organization in particular, some of these policies have been in place since the 80s. Okay.
Hmm.
And we were updating. And when you look at the revisions and the updates, you see the updates, the update, and it's really the same policy. And it probably would, over the years, there's probably, maybe 3 changes or 3 or 4 changes, but there's no huge change in the policies. And we need to get our policies to be more in line with today's society of nursing.
Yes. Yes. Because I think sometimes we kind of shift and go overboard, right?
Right.
So I remember when we had this incident years ago. This is in the 90s, and so nurses were wearing false fingernails, and one baby got an infection, and then it was like, everybody, now you got to get rid of all your artificial nails and all this stuff, and it just kind of went overboard. You know what I'm saying? So it's this sweeping thing, and I'm thinking, okay, does this make sense? Now, I personally don't think that artificial nails belong in healthcare because they can't harbor germs. And if you ever broke one of those things, ow, okay, that hurts. I don't see how they do it. But we have to make common sense approaches. I mean, when I started out as a CNA, they didn't even wear gloves. If you wore gloves, you were looked at like you're a weirdo or something. It's like, what's wrong with you? And I'm like, I'm wearing gloves because I know about germs. I'm a biology major. I know about germs. I'm
Right.
wearing gloves. But I just remember seeing CNAs, older CNAs just doing bed baths and pericare and using their bare hands. And I'm just like, ooh.
Right, right,
And then
right.
going
Yeah.
from resident to resident without washing their hands, right? And so we've come a long way in some ways, but we haven't come as far as we should. And I think we should look at some of those policies and say, why are we doing this? Does it make sense?
Exactly. Exactly. And you know what? So, and then we also have to make sure who's writing these policies should be writing these policies. And I'll
Yes.
give you an example. I remember one time, one of the organizations that I worked for, the person who created the restraint policy, again, because we were looking at these policies and we were wondering, like, what is this policy talking about? Like, where's this verbiage coming from? She had gotten the policy from a different state, and it was one of the hospital's sister companies, within the system, that was in somewhere out in the Midwest, and she was using that policy. Now, New Jersey's restraint policies are completely different than what they may be in the Midwest. And I'll give you an example. So in New Jersey, you have to have, say you're doing a medical surgical restraint, soft restraint, bilateral, that order needs to be renewed every 24 hours.
Hmm.
And nurses aren't, we need an order. And
Right.
the way her policy read was, the nurses can renew the order and they have to document it. And we were all like, and I remember I was fairly new to the organization. And so I'm going through the policy and I'm just like, who wrote this? Like, where did it come from? And then come to find out, and what had happened was Department of Health had come, and they had questioned one of the nurses about the policy, and the nurse spoke to the policy. She was right because she spoke to the policy. However, that wasn't the state law when it came to restraints. So when we drilled down, we found that the restraint had been taken from another hospital from out in the Midwest. And I'm just like, what, like, why is this happening? So I say all this to say, who's writing the policy, they need to know. And I'll even take it a step further when it comes to insurance companies, right? I know you mentioned insurance companies
Hmm.
and authorizations earlier, and I was having a conversation with a physician, and one of his biggest pet peeves are authorizations, right? And it's because some of the people who are approving or denying these authorizations are not nurses, they're not clinical. You're denying a possible surgery or procedure that can really benefit my mother or my father or my loved one, and you're not even a nurse. You don't even have a background. And I'm not saying that they don't have any nurses or healthcare professionals working with
Hmm.
these insurance companies, but the people who are doing they're just going following what they think, following the not what they think, but they're just following their rules and their
The
regulations.
algorithm. Hmm.
Right, right. They're
Yep.
not necessarily, they don't know or really understand, at least I don't believe, what they're looking at, because you would not deny this person to that something that's going to, prolong their life, or something, a procedure that is going to remove an infection or remove a mass or remove, something foreign from it. You're not going to deny that procedure for something that needs to be done if you understand healthcare. So it's frustrating. So yes, there's definitely, policies and regulations that definitely they need to be updated and they need to be changed.
I agree, and we could go on and on about who is driving healthcare, because a lot of healthcare right now is being driven by private equity firms. And why do we have people that own real estate? Why is a real estate firm owning a hospital? Anybody
So
ask those
so
questions?
let's talk about that. Let's talk about who's on the board of trustees of these hospitals, right? They're
Hmm.
pushing for, improve the patient experience scores, improve the patient experience scores. We got to improve our responsiveness. We got to do this. So we want our staff and our nurses to do more for less. But guess why? They're coming from a finance background. So they're looking at the numbers, right? They're looking at the numbers, and these are the board of trustees for, banks that I won't necessarily mention, but but do know that your board of trustees are not who you would think it is. right? It's
No,
like you said,
they're
real estate
hotel
companies.
owners. They're hotelers. So
Exactly, exactly, exactly.
they're
So
in
they're banks, they're
hospitality. Yeah.
real estate companies, they're all of these
Mhm.
high profile. They're the ones who are running the hospitals, right? The
Yep.
CEO, CNO, we're just the faces, right?
Right. Yep.
Let's please understand. Yeah, yeah, yeah,
Because they
yeah.
have to answer to their shareholders, and
Right,
the
right.
shareholders want a return on their investment. And so, how they get away with it is that these private equity firms come in, they put some money, just infuse the hospital with some money, right? And they buy the hospital, and then they sell the land that the hospital sits on. So now the hospital has to pay rent on land that they previously owned, and they lease the land back to the hospital. And then when they sucked all the profit out of that hospital, then they go and sell it to another private equity firm, and the cycle begins all over again.
Right. And no, I don't know if it was Minnesota. It was a state. I don't know. I could be wrong with Minnesota. I forget which state it was, but there was a strike. And what the nurses did, they actually went to the banks of the board of trustees, and that's where they picketed outside of those banks or even within those banks. And that's where, well, they picketed, they let them know that they were there. They went picketed outside of those
Mm-hmm.
banks because guess what? You're on the board of my hospital where I'm striking, and I need you to understand. And I said, that's how you do it. That is
Yep.
exactly how you do it. You strike at the place that the people who are on those board of trustees. That's how you do it. Now, I'm not, encouraging striking. I'm not, with it or against it. Let's be very clear. My point is that's how you get your voice heard. And these are the type of things that I talk about on my podcast as well, Nurses with Voices, because this is how you give yourself a voice. This is how you give nursing a voice. And unfortunately, sometimes that means going on strike, right? Or it could just mean really being a part of, elevating the voice, whether it's through, having, encouraging. I'm not going to say encouraging strikes, but encouraging your voice be heard at the legislative level, right? Getting a policy in place where there is staffing, what do you call it, the ratios, right?
Right.
There is a cap, I want to say, on how many patients nurse can care for, and making that nationwide instead of just in certain states.
Well, I think
These are
that
the things.
every, sorry to interrupt. I was going to say, I was thinking every board, hospital board, should have to have a nurse on the board in a voting position.
And you're right, because that's how you move the needle. And it has to be a strong nurse. You don't want a yes man, right? You don't want a yes man and someone who they're actually going to listen to. I can remember, sitting in leadership meetings, and I had a CNO, and my CNO, she was African American at the time, and they would speak to her like she was a charge nurse. Right. And it's because you have to own your presence. You have to be willing to advocate for you're the chief nursing officer. You have a hospital full of nurses who you have to advocate for, and you have to be able to have a presence and have a voice that they're going to listen to. So it's real that piece is really important. If you're going to take that type of stance, you really have to be willing to have that voice for nursing, and be wrong sometimes, right? And be
Mhm.
willing to, not just go along with what the majority says. You have to be able to speak up, and because sometimes they don't necessarily know. I mean, I've sat at those tables with, non-nursing, right, who are in these executive positions like COO and other positions, and they don't get it. Like, they don't understand what happens at the nursing level. I can remember opening up an intermediate care unit, and I didn't have a medical director. Then I finally got a medical director after fighting for that FTE, and creating policies so that there was an understanding of what type of patients needed to come on my unit, because you just can't send the patient. It doesn't make them an intermediate care patient because, oh, they need a lower ratio. No, but why does the patient need to be step down? Right. But these are the type of conversations that need to be had at certain levels. But again, there's not a good understanding when there's not a clinical background. So
Yeah, I find that having that clinical piece is so important to understanding the day to day. And I'm going to say, if you're listening, you just happen to be on our find our podcast, and you're a hospital administrator or a nursing home administrator, and you don't have a clinical background, why don't you shadow your nurses? Spend a day, an actual day, with your nurses so that you can at least get an understanding of what happens on the day to day. Now, I know that that will probably make them nervous as all get out, right? But if you do it in a way of saying, I want to understand you and what you go through every day, and I encourage you to do that in every department in your hospital, every
Absolutely.
from maintenance, housekeeping, dietary, radiology, wherever you need to go, spend some time with them and really spend some time with them. Don't just do the high wave and I've been here for an hour and I got to go because I got to go to a meeting. No, you take your time and you ask questions and you be intentional about it and you listen, listen, as opposed to wanting to tell them the solution. Let them give you the solutions, and then you can take it back to your team and say, this is what I learned. It would be great if they could do like an undercover boss in a hospital.
I love that you bring that up. So one of the things that I do as a part of consulting, as I mentioned, I consult with organizations, and that's actually something that we advocate for, which is walk a mile in my shoes is what we call it, and walking a mile in my shoes is pretty much what you just explained. It's really having that top down approach, right? And you coming and just shadowing me and understanding, not just coming to the units and holding a meeting and taking me away from my patients. Coming to the unit, yes, it does include having focus groups as well, but it's also really understanding and being present on the unit. Even if you see them do something wrong, that's not the time to do it, right? That's not the time to course correct that behavior, because you're just really there to watch and really get an understanding of what a shift looks like. Now, do you need to come for the entire 8 to 12 hours? I'm not saying that, but you do need to come for a significant amount of time and be present so that you understand what the goings and comings look like on the units. And this is, or and if it's not a hospital organization, if it's a clinic, or if it's another small business, because sometimes business owners may have separate sites for separate businesses, and but it's being present so that you see what that day to day looks like. So to your point, I can appreciate you bringing that up. Hospital administration, that is definitely something that you can implement, and that's what we help you do with James Consulting.
Okay. All right. Well, we're getting to the end of our time here, and I do want to thank you for coming. So I want to ask you our final question. Um, and before we do that, I know you have something that you are offering to our guests. You have a free guide for nurses to beat burnout. So tell us about that and where they can get that.
Absolutely. So that is, I'll give you the, I should have given you the link. They can actually, it's a free download, and it really is helpful in, basically, in a nutshell, what you just said is to beat burnout. And what it does is it goes through actionable strategies, and these are evidence-based strategies that you can use that really will help you start to prioritize your self-care, prioritize, what your wellness journey looks like, what your wealth journey looks like, all of the things that you really need to put in place so that you can start really living better. It talks about doing little tweaks, little shifts to your lifestyle. And I'll give you an example. One of them is, and I mentioned this earlier, is setting boundaries. One of the saying no, right? One of them is, it talks about, being more physical with exercise, the things that we eat, looking at what we eat, how we can eat different, journaling, what are you doing in, what does your morning routine looks like? What does your daily routine looks like? These are the things that if we can start implementing, we can really start to change the trajectory of where we're going, instead of, really spiraling down into burnout, because burnout can be very debilitating. And and it's a symptom, right? And we have to really identify where the symptom is coming from. So the guide really helps you to really start putting things in perspectives and start to help you make a couple little shifts in your daily routine, or in your lifestyle as well.
So I do have the link, and I'll be putting that in the show notes. But if someone wanted to reach out to you and maybe talk to you or about their burnout, or is an organization that wants to get in touch with you, how best can they get in touch with you?
Sure. So I'm on LinkedIn. My website is dljamesconsulting.com. If someone is interested in attending the Health and Wealth Expo Live Summit, if you're in the National Harbor area in Maryland, that will be on October 24th. And from 9 a.m., it's a one-day event from 9 a.m. to 6 p.m. And that website is Health and Wealth Summit 2024.com. That's Health and Wealth Summit 2024.com. And, you can also find me on my podcast, Nurses with Voices. I'm on all of the, all of the podcast platforms, wherever you get your podcasts.
All right. All right. Thank you. So, lastly, our last question is, if you had a piece of advice for a budding nurse entrepreneur, what would it be?
My advice would be to grow a team. Being an entrepreneur is, once you get to where you want to be or need to be, your businesses can run like a well-oiled machine, but you have to have a team in place. If you try to do everything on your own, you will burn out. I know, people are shifting from traditional settings of nursing, and, a lot of them went head on into being entrepreneurs and quickly realized, like, I don't know if I can do this, or felt like they couldn't do it. But you know what, you can. It's important to have that team behind you. And, and if you're a person of faith, I know I am, you definitely have to do your journaling, do your prayer, and, just manifest that team into your life, because your team is really going to be able to make a difference in your business, because you can't do everything. And as we talked about earlier, that's one of the things that we do as nurses. We're used to doing everything, right? We're used to being housekeeping, as we talked about. We used to being dietary. We used to being a nursing assistant. We're used to being the nurse. However, when it comes to running your business, you can't take that same mindset into having a business. So definitely make sure that you get a team. Get someone you can trust, get people, I should say, that you can trust, and start off small. In the beginning, you don't need to have a big team in the beginning, but as you progress and as your business grows, and when you see the vision and where you want your business to grow, definitely get a team.
Definitely. All right. Well, there you have it. I want to thank you again for your time. This has been great. You were wonderful, and I love your energy.
Thank you.
So
I had a good time with you as well.
great. This is the Nurse Shark Academy show. I want to thank those of you who are listening. If you're watching us on YouTube, don't forget to subscribe and to hit the notification bell so you're notified of all of our episodes. Also, if you're listening to us audio, you can get our podcast at Podbean or wherever you get your podcasts. And if you know a potential guest that might be on the show, go ahead and reach out to the Nurse Shark Academy. And you can reach us at the nursesharkacademy.biz, which is our website. I want to thank you again, and we'll see you next time. Hello. Thank you. And I wanted to announce that the Nurse Shark Academy show has been nominated for the 2025 Women in Podcasters Award in the category of careers. I look forward to the voting season. It starts in May. Stay tuned to hear more information about how to register and vote for our show, the Nurse Shark Academy show. Thank you for listening to the Nurse Shark Academy show wherever you get your podcasts or watching us on YouTube. Don't forget to like and subscribe, and don't forget to hit the notification bell so that you'll know when all of our episodes come out. If you want further information, you can contact us on the nursesharkacademy.biz.